Good afternoon. My name is Dr. Brian Levine, and I'm a practicing reproductive endocrinology and infertility specialist based in New York City, but also a global consultant for the Well Women's Center at the Reliance Foundation Hospital. It is truly an honor and a pleasure to speak to you today about a topic that is so incredibly important. Many patients will come to see me in New York or in Mumbai from local or around the world. And as couples are struggling with the truly challenging diagnosis of infertility, one of the most important things to share with people is that the diagnosis of infertility is a general one, typically defined by someone who is under the age of 35 trying for 6 months, or trying for a year, or over 35 trying for 6 months with no success in getting pregnant. When we take a step back and we look at the patient who's undergoing the real struggles of infertility, it is so important to explain to the patient that a proper diagnosis starts with a proper workup, which can ultimately lead to a most successful treatment plan. One of the biggest challenges that we find when speaking to patients at the Well Women's Center about infertility is helping people understand that both the male components and the female components are equally important in making these critical diagnoses so that we can have the absolute best treatment plan possible. As a clinician, one of the things that I value the most is having a meaningful workup for a patient that's done in a timely, but most importantly, reproducible manner. Rushing through a workup or having a workup done in multiple different centers only leads to more confusion, more time, and more tears. Because we know that when people are unable to get their questions answered, when they can't find out why they're not getting pregnant, when they can't find out how their path to pregnancy will be, it's incredibly frustrating and disheartening. When talking to patients about fertility testing, many patients are scared. Many patients are almost nervous to make an appointment to go start the fertility testing because they don't understand what is involved, what's going to be done, and sometimes are even scared of the outcomes of the testing itself. What I'm going to do for you today is walk you through what we like to call the one-day workup, the way that we can take the most sensitive part of your reproductive journey, the beginning, and help you understand who you are, what you need, and most importantly is how you're going to get to either start, grow, or complete that family that you so deeply desire. At most fertility clinics in New York, in India, and around the world, traditional fertility testing can take weeks or months to complete, but a one-day workup allows a patient to complete their testing in truly a timely fashion. First and foremost, it starts with a conversation, either with the female partner alone, or the female and male partner together, or the male partner alone sometimes. But it always starts with a conversation. As I like to say to my staff and to those who I've trained over the years, if you don't know the patient and you don't know the story, you can't know the plan. And knowing the patient and knowing the story is part and parcel of doing the diagnostic evaluation. So first and foremost, it always starts with a history, understanding how long someone's been trying, understanding if someone has regular menstrual cycles or not, understanding if there's any sexual performance issues for the male partner, and most importantly, listening to the patient. Tests are wonderful. They offer objective insight when seeing a patient. But a conversation with a patient is most important because a conversation helps us truly understand who is sitting in front of us and what we need to do to help them get there. So first and foremost, a consult with a clinician and a consult also with a member of the staff to make sure that we have a complete medical history is key. I always remind patients before you make your appointment, or even before you show up to your appointment, do everything you can to collect your information. There's no such thing as a silly question or a silly comment. So if you think something is relevant, write it down. Make sure you don't forget. Email us, bring it to us, message us. There is no piece of information that you can provide that's not relevant. So we welcome you to bring whatever you can. After the conversation, the female partner will undergo a baseline ultrasound. This ultrasound is typically done with two different modalities. The first modality that's done will be a transabdominal ultrasound, and this will help us better understand the anatomy. What is the alignment of the uterus? Do we see both ovaries? How do we understand if there's any fibroids or benign growths that could be there? And understanding the general anatomy of the female reproductive tract. Then, typically, a transvaginal ultrasound is done. Transvaginal ultrasounds afford us the ability to have a true high resolution evaluation of the uterus, the fallopian tubes, and the overall reproductive genital tract. A transvaginal ultrasound can afford us a ton of information. I always start by assessing the uterus. From the transvaginal ultrasound, we have an understanding of the cervix, which is ultimately the bottom of the uterus. We then have an understanding of the shape and the direction of the uterus. We have an understanding of the lining of the uterus. Is this lining hospitable for allowing an embryo to implant or a baby to grow? Or do we see any irregularities or malformations within the uterine lining itself? For example, a polyp or a fibroid, or anything that would cause an irregularity along the way. Many people are surprised to know that fibroids and polyps are incredibly common, but left untreated can be a cause of infertility. And the treatment for them is surgery, not IVF, not running down to take medications, but sometimes it can be a quick surgical procedure as an outpatient to correct a uterine anomaly. But a truly well done, high resolution transvaginal ultrasound affords an assessment of the uterus that is truly key and paramount to understanding who the patient is in front of us. Furthermore, when we are doing our ultrasounds at the Well Women's Center, we always advise patients to have a three-dimensional ultrasound done at the same time. A three-dimensional ultrasound is effectively a number of two-dimensional images that will be digitally stitched together to afford the clinician and the team an understanding of the orientation, direction, and to take a high depth of view or high density view of the lining of the uterus to understand if the environment is perfect or needs to be improved as we move down this fertility journey. A transvaginal ultrasound also allows for an assessment of the ovaries. The assessment of the ovaries always starts with just understanding the size and the volume. Does someone have large and normal and plump ovaries? Or are they very small or streak and difficult to visualize or difficult to access? Furthermore, when we look at the ovaries, we look for the presence or absence of cysts. Cysts are not always dangerous, and cysts are not always bad. In fact, a cyst just means in Latin a fluid-filled structure. But sometimes ovarian cysts can be the cause of the problem of why someone's not getting pregnant or staying pregnant, especially if they look hazy, like an endometrioma, or they're associated with a disease called endometriosis. Furthermore, when assessing the ovaries and doing a three-dimensional study of the ovaries, we want to better understand the antral follicle count. The antral follicle count, or the AFC, is a measure of how many eggs do we see at the timing of this ultrasound. Now, of course, these are not the only eggs that someone will have their entire life, but this is a very rough assessment, although a good assessment, of the reproductive potential of someone if they were to go through in vitro fertilization and be stimulated with hormones, how many eggs they might retrieve at the time of collection. So antral follicle count, ovarian assessment, ovarian volumetric assessment, and ovarian pathology is a key and part and parcel of this transvaginal ultrasound. Of course, depending upon the timing of the cycle and where someone is in their cycle, either if they're bleeding or not bleeding, and if they're not bleeding, we might be able to do at the same appointment something called a saline sonogram. Saline sonography is by putting a little bit of water inside the cervix, into the uterus, to take a better look at the cavity of the uterus, to take a better look at the lining of the uterus. Now, if someone's not in the right phase of their cycle, that is okay. We can always have them do another study at a later date because a transvaginal ultrasound is no radiation. right? We know that there's no negative detrimental harm that will be done to the patient by having a repeated ultrasound. In fact, what we would often say is that during this 1-day workup, we prefer that the patient is on the earliest phase of her menstrual cycle, days 2, 3, or 4, and they come back for what's called a mid-cycle lining assessment, where we can take a look then at the lining of the uterus and potentially do this saline sonogram around days 9 or 10 of their cycle. At the same time that the female partner is having this ultrasonographic studies being done, we would ask that the male partner provide a semen sample. A semen analysis or semen study is the key diagnostic test to understand the male reproductive potential. The semen analysis has 4 key components to it. One is the volume, or how much semen is present. Second is the count, or the concentration. Third is the and how well they're swimming. And ultimately, the fourth is the morphology, or the shape. The fourth finding, or morphology, shape, is the most subjective of them all. However, even though it's a subjective assessment, we are keenly attuned to looking at all 4 parameters to understand why someone may not be getting pregnant or staying pregnant. Many patients are shocked to learn that of the patients that we see, 1/3 of all patients have a female factor or female cause of infertility. 1/3 have a male factor cause of infertility, and 1/3 have a combined or unexplained cause of their infertility. The 1/3 male factor can almost always be picked up with the first screening semen analysis, which is why it's so important to collect this specimen on the day of the 1-day workup. Of course, both patient and partner will go through blood work and diagnostic testing as well. And the 2 key things that we're going to be looking for in that blood work is both the communicable disease testing. So those are the infectious diseases that people may carry. But more importantly, is also looking for the genetic testing. And in the genetic testing, we want to understand, are there any conditions or diseases where 2 partners might overlap? In essence, are we picking up that there might be a disease, for example, that could be had of this child, and that because they've not gotten pregnant, they've actually not had a negative outcome? In fact, are we almost glad they haven't gotten pregnant yet? Because the risk of them carrying a condition that they could pass on to a child could be 25%. With that said, we also do, from that same blood test, general health assessments. I remind everybody that seeing a fertility doctor means you're seeing a reproductive endocrinologist. Reproductive endocrinology means reproductive hormones, and the interplay of the hormones in the human body are part of a very complex integrated system. In fact, understanding the integrated complex system means that taking a top-down look, understanding the hormones that are in the pituitary gland, which includes things like prolactin, follicle-stimulating hormone, luteinizing hormone, thyroid-stimulating hormone, understanding the health of the thyroid gland itself, because the thyroid gland is the gland that is so important for creating homeostasis and the metabolic control of the body. And also understanding how the reproductive organs themselves are messaging back to the brain, looking at hormones in women such as estrogen and progesterone, which are created by the follicles within the ovaries. And in men, of course, looking at testosterone, which are made by the testicles. Once the blood work is done and the blood tests are done, we then have the patients talk to the counselor, to talk to the genetic counselor, because although the blood work was done for genetic testing, the key for genetic testing is getting a good family history, understanding if there's any family members who've had reproductive issues in the past, if there's any family members that have a child with developmental delay or a disability. And then most importantly is meeting with the clinician at the end of that 1-day workup. At the end of those few hours, understanding what is the path forward, understanding what tests are still waiting to be done, what clinicians need to be seen. Putting together a comprehensive assessment for a patient is so critically important. In fact, I will argue that as a doctor, it is the most important thing that I can do for a patient is to know their story and to know their treatment plan. Because patients come to see us asking us, what more can we do? What more can we do to hopefully start, grow, or complete our family? Because as we all know, fertility journeys can be quite rocky and can be quite emotional. The next steps after today is that we hope you understand that the Well Women's Center at the Sir H.N. Reliance Foundation Hospital is completely motivated and aligned in helping patients have the single best outcome possible. That outcome is what you want. That outcome is either your family starting or growing. And what we are committed to at the Well Women's Center is carrying out the treatment of our patients in a personalized and compassionate manner that's both efficient and effective. I thank you for your time today. I look forward to seeing you in Mumbai, and we thank you for all of your questions. And as you submit your questions online, we'll be sure to get back to you shortly. Thank you so very much, and I wish you the absolute best of luck on your fertility journey and your reproductive journeys. Thank you.